I'm Roger Elizabeth. I'm the caregiver and husband for Lucy Elizabeth. Lucy was diagnosed in November of 2010 with early onset Alzheimer's at the ripe old age of 62. She's been my best friend and the love of my life for over 50 years now. When originally diagnosed, to be honest with you, we didn't know much about Alzheimer's. We didn't know what to expect. We didn't know what was in the future for us. After about a year of research and working with people with the Alzheimer's group and some UCI people, we realized that this horizon was not that terribly far away and that we should start to make some longer-term plans as to what we were going to do. With that said, we went to our attorney, we redid our wills, we redid our trust, and I became power of attorney for everything that Lucy does in life. Good that we did that, because 2 years later, Lucy was no longer able to sign her name. And had we not done that in an early time frame, it would have made some of the things that we do in life much more difficult, like selling cars or refinancing homes or those kinds of financial deals. Having been diagnosed back in 2010, we are now in what I call the third phase of 3 phases. We're in the final years, and it's always been helpful from the people at UCI as well as our association with the Alzheimer's people to get an idea and get a little bit of an expectation of what might be next in the horizon. Every one of these cases is a little bit different, so there's not a roadmap. There's not a book that you can open to chapter 23 and say what's next. But at the end of the day, there's a broad enough implication from what we are able to get from the UCI people as well as the Alzheimer's people to say, this is the next step. This is what we need to be prepared for.
We're very pleased that Dr. Lynn Flint has agreed to join us and walk us through a discussion of end-of-life care. Dr. Flint is associate professor at UCSF. She did her medical training at New York University, followed by internship and residency at the Brigham and Women's, Harvard, in Boston. She did fellowships in hospice and palliative care at the Greater Los Angeles VA, teaching scholars program at UCSF, and a leadership in education and development program at Association of American Medical Colleges. Please join me in welcoming Dr. Flint.
Hi, everybody. Just going to see how close I can be to the mic. So I think the speaker who spoke before me said they had the unfortunate placement of going between sex and lunch, and now I get to talk about death after lunch. Might be less lucky placement, but I'm always talking about death, so I guess that's just kind of what I do. First of all, I just want to say thank you. I was really excited and honored to get the chance to come here and speak with all of you. And watching these videos has been really touching, and hearing your questions. I was sort of, during the last talk before lunch, I was really kind of just overwhelmed with gratitude for the work that all of you do, whether you're caregivers or working in the facilities. The amount what brings you here is that you care about people with dementia in some way or another. So thank you for that. And I just want to highlight how important that is. I don't have any disclosures. And today, because I'm a rule follower, I'm going to list the objectives that the conference planners would like me to have you guys meet. So what I'm hoping is that at the end of this talk, you will be able to identify common end-of-life care decisions that are confronted by individuals with dementia. Also, I'm going to talk about the difference between hospice and palliative care. And then I'm going to talk about how healthcare providers can help patients and families make some of these difficult decisions. But I'm going to start with a little bit of background, just a little bit. And to me, this is the big elephant in the room. Dementia is a progressive and life-limiting illness. It's a terminal illness. And this is really hard to talk about, and I recognize that. It might even be harder to talk about than sex, although maybe not. But it's progressive and life limiting. And the interesting thing is that a lot of the medical community doesn't fully have an understanding of that, actually. Dementia could only be listed on death certificates as of about 24 years ago as a cause of death. So it was in the 90s. In 2009, a group studied a cohort of patients with dementia, people with pretty advanced dementia, so people who needed help with their activities of daily living, and were advanced enough that they did not recognize their family members. These were people in nursing homes. And they basically just followed them, observed them over years to see what happened to those folks. And what they found was that there was a tremendous burden of suffering. People, first of all, more than half of them died by 18 months. So these are people with advanced dementia, more than half of them died by 18 months. That's a prognosis that mirrors many metastatic cancers and also heart failure. Infections were really common, especially towards the end of life, and eating problems were nearly universal. They were seen in over 85% of patients. They also documented evidence of pain or shortness of breath or both in more than 1/3 of these people. And this was in 2009, as I said, and that study got a fair amount of press. And the press was around, wow, dementia is something that is terminal. So that was kind of a big deal. Dementia is also really common. Nobody knows that better than all of you in the audience. But it's actually a common cause of death. So in 2014, which is the last year that we have data, Alzheimer's disease was the 6th leading cause of death in the United States. And I suspect that that is actually higher than number 6 because many medical professionals do not list dementia still as a contributing cause of death for people. So I'm guessing that it's higher. You can see in the background it's things like heart disease and cancer and other things that actually the risk of the rate of mortality is going down from those diseases. Alzheimer's is going up. It's not clear if that's because more people are writing that down or because the actual rate is going up. So I want to move on to some of the decisions that come up as a patient and family go through the journey of having dementia. And I'm not, unfortunately, going to give you the answer to any of these decisions because they're very individualized. So I would be remiss if I did not mention advanced directives. They've already been mentioned a couple of times, but I wanted to briefly mention them here. An advanced directive is a piece of paper where a person can designate who would make decisions on their behalf if they could not do so themselves. That piece of paper is called a designated power of attorney for healthcare. An advanced directive might also contain another piece of paper called a living will, which describes what sorts of treatment or types of care would be okay or not okay for that person as they're dying, in their dying process. People with very advanced dementia generally lack the capacity to name a surrogate healthcare decision maker. But people earlier in the stages of cognitive impairment certainly can retain capacity to say, this is the person who I would like to speak on my behalf. So it's important to think about even after the diagnosis is made. Another huge decision that comes up that I'm not going to dwell on because I feel like this is something that you all are so much more familiar with than me, is care setting. The reason I bring it here is, or I have it on this slide, is because when I'm teaching medical students, fellows, resident doctors, they don't think this is a big deal unless they've really been through it in their own family. And that is when somebody has to move out of their home or they have to use their financial resources to hire a caregiver, where they're going to go, what that place is going to be. It's a huge deal for families and a big decision that healthcare providers actually can help think about. And then after thinking about care setting, another big decision that comes up is what we call code status. Have you guys heard this term before, code status? DNR, full code. I used the real term there because that's how we throw it around in the hospital. And I am the last person to advocate for the menu of options approach to making decisions about end-of-life care. And yet this comes up and is very important for families and I don't think is going to go away. So as a person with dementia comes into the hospital or comes into a nursing home, the family is frequently asked, Would you like the team to attempt resuscitation for your loved one? And that's a very personal decision. I'm not going to give you the answer to that right now. I am going to talk a little bit later about how providers can help. The other one is hospitalization. Something, a lot of people don't think this is a decision, but it actually is. So when a person with dementia, in particular, more advanced dementia, goes into the hospital, there's a lot of hazards associated with that. There's worsening confusion, which now we have evidence that episodes of worsening confusion on top of dementia may actually worsen the trajectory of dementia. There's infections that can be acquired in the hospital. There's falls. The list goes on and on. So there's a lot of burden associated with going to the hospital, and families may need to weigh whether that burden is worth whatever benefit a person might get from going into the hospital. Excuse me. The next one is eating problems. As I said earlier, eating problems are nearly universal in people with advanced dementia. And I'm not going to actually dwell on the data around feeding tubes in advanced dementia. I'm sort of happy to see that it seems to be kind of out there that feeding tubes, when compared with careful hand feeding for dementia patients who have eating problems, there's no benefit in terms of length of life, quality of life, pressure ulcers, and in fact, there's probably associated burdens, including falls, delirium, restraint use, and so forth. Even though we know that, and it's finally kind of starting to get out into the community, that doesn't make it any easier to watch your loved one be unable to eat or drink. And lots of families still ask about this, and so it becomes something we talk about all the time. And finally, then there's that decision about hospice, which I'm going to talk a little bit more about later. And when might it be time to transition to hospice care? Excuse me. So I also just wanted to illustrate those decisions with a story. And I'm a little bit putting myself out there right now. I'm making myself vulnerable because I'm going to tell you the story of my grandmother's death about 10 years ago. And that's why I have Queens in the background, because that's where she lived. The reason I'm telling that story is because I work in the hospital and in the nursing home. So I take care of plenty of people with dementia, but usually for the last year or two of their life, or maybe I see them as a consultant a few times in the hospital. But I rarely get the opportunity and pleasure to take care of somebody from diagnosis to the end of their life. It's kind of one of the drawbacks of being a consultant in the hospital. So I thought, maybe I should use my grandmother. So here's what happened to her. She was living alone. She had been living alone for about 40 years in a 2-story house in Queens. Her husband died when my dad was a teenager. Very steep steps in that home, and she fell and broke her hip. She'd been getting along okay. She was having occasional lapses in memory, which we kind of just chalked up to age. But then she fell and broke her hip, and the red line is functioning. And obviously her functioning dropped precipitously with that hip fracture. Went to the hospital, had surgery, went to a nursing home, did some rehab time, got back to being able to walk with a walker, although she didn't have a walker before. And she got ready for discharge. The nursing home said, great, she's done as well as she's going to do with rehab. We're ready to send her home. And my dad was like, how are we going to send her back to this 2-story home with these steep stairs? And so they had to make difficult decision number 1, which was moving her into a 1-story apartment. She didn't even have her diagnosis yet. She got into her new apartment, and she seemed to have more trouble with her memory and kind of trouble just managing her much smaller household. And my dad started having to drive out to Long Island more frequently to take her to the grocery store and kind of check on things, make sure things were going okay. And he also took her to doctor's appointments. And finally, during one of those appointments, after talking about the decline and the troubles that she'd been having, she got her diagnosis of dementia. And then one of those times when my dad was taking her to the grocery store, he was standing on the curb with her, and she stepped off the curb funny, and she fell and she broke the other hip. Called 911, she went to the hospital, got surgery, went back to a nursing home for rehabilitation, And that time, she just couldn't carry forward to the next day what the physical therapist had told her the day before. She was already walking only short distances with a walker, and at this point, she really could barely do that. She was mostly in a wheelchair. And so another huge decision came up, which was, where is she going to go? She can't go back to her apartment. And that was incredibly difficult because this very independent person who lived on her own for so many years now was having to go into a nursing home. And she had a hard time expressing in words that she was upset, but we knew she was upset. She wasn't able to necessarily say, I don't want to go to a nursing home, but she was definitely able to say, I don't want to go there. And she did. We found a place that was very nice. It was closer to our house, and she moved in. And she declined a little bit further after she got there, but she kind of settled in, spent most of her time up in a wheelchair. There was a bird that sat in a cage outside her room. She spent a lot of time by that window, and kind of did okay. There was a doctor that visited the nursing home once in a while, and the nurses provided, of course, all the care for her. And then she developed a fever, and in the evening, my dad got a phone call from the supervisor nurse that night and said, she has a fever, she has a cough, we think she probably has pneumonia. What we normally would do in this situation is send her to the hospital. Is that what you want us to do? And so my dad said, okay, yeah, if that's what you would normally do, what other options are there? And so she went to the hospital. And then my dad got a call from the hospital. They said, she's actually really sick. She's in the intensive care unit. This was sort of in the first 24 hours. Have you thought about her code status? I don't know that the doctor used that word, but I think he might have said something like, have you thought about a DNR? And my dad talked with the physician in the ICU. The physician they didn't have a lengthy conversation, but it was like, I see she's really sick. I see she has a history of dementia. Seems like maybe a DNR would be a good idea. My father knew that she really wouldn't want her life to be artificially prolonged in her current state. And so he did sign a DNR, but again, even though he had near certainty that this was what she would have wanted, this was a really difficult decision made virtually in the absence of support, external support outside of the family. Fortunately, she made it through her ICU stay. She didn't end up needing or getting close to sick enough for a ventilator. She made it out of the ICU, back to the nursing home, and as you can see, she kind of dipped in her functioning a little bit, but hung out in the nursing home. And then eventually she did develop some eating problems. She just wasn't eating much, and the team at the nursing home mentioned, the nurses said, we have to hand feed her, and we sort of sit with her and encourage her. And she would pocket her food a fair amount in her mouth and just not eat so much. But it was never presented to us that a feeding tube was on the table as an option. It was explained to us as just sort of part of the natural process. There wasn't a lot of back and forth in the conversation. It was just kind of like, this is what's happening. We expect this to happen. And then a little while later, again in the middle of the night, my dad got a call. This time it actually was from the doctor from the nursing home. And he said, she's really sick. She's obtunded. She's got a fever. Her feet look purplish. I think she's going to die soon. And I don't think we should send her to the hospital. And so again, my dad said, okay, and rushed over there. And indeed, she died within about 12 hours. So I think there were a lot of, while we did get help from professionals along the way, and there were a lot of people who were engaged and cared about my grandmother throughout this. I look back at this now, this was sort of in the beginning, back in my medical school years, and now being out in practice for a while, 10 years, more than 10 years have passed since this happened. I look back as a palliative care doctor and I think, wow, there were a lot of opportunities to help with the stress of what was going on. Not only for my grandmother, who probably had a fair amount of suffering, but for my dad, who was really operating on his own. I should say that my dad is a medical malpractice attorney. Somehow I still became a nursing home doctor, which is a high-risk job. So he has a lot of health literacy, and he, and he struggled tremendously. So there's a lot of points where an extra team could have really helped. And that team is palliative care. That turned out to be what I went into. So part of my job today is to tell you what palliative care is. And as I was speaking with the people sitting behind me, I was explaining that the Center to Advance Palliative Care years ago, in response to the notion that lots and lots of people in the community were associating palliative care with death and dying only, they engaged a market research company to try to come up with an appropriate definition of palliative care that would make sense to patients and families. And I gave you some snippets of that definition here. I'm just going to read it off. So palliative care is a type of medical care for people living with serious illness. The goal is to improve quality of life for both the patient and the family, and it's provided by a team. It's appropriate at any age and any stage in a serious illness and can be provided along with curative treatment. The key point of showing this definition is that the word death, dying, end of life, terminal, poor prognosis, none of that's in there. So you don't have to be dying right away to get palliative care. You don't have to be dying at all. There's lots of cancer patients, for example, that we take care of in palliative care who are going for a cure of their cancer. So what does palliative care do as a team? So again, palliative care is a type of medical care. It can be provided in a lot of different settings. There are some home health agencies here at the conference who are providing palliative care in the home. I provide palliative care as an inpatient consultant in the hospital. There are also outpatient palliative care clinics in a lot of institutions. And it's a team. It often includes these 4 disciplines that I've listed here: nurses, physicians, social workers, and chaplains, but can include lots of other disciplines depending on how well funded the institution is, or the team. And we do, first of all, symptom management, which includes pain management. We take care of all the other things that come up with serious illness: shortness of breath, depression, anxiety, constipation, poor appetite, a whole host of things, all the physical symptoms that can come up. There's also a tremendous amount of psychosocial and spiritual support that our team offers to patients and families. We also help with determining goals of care. What does that mean? I'm going to talk a little bit more about that later, but it's really just trying to figure out what's most important to the patient and family, and how can we help the healthcare system match that person's treatments to those goals so they can meet those actual goals. We do a lot of help with coordinating care because a lot of times there's many specialists involved in people's care when they're seriously ill. We also help with transitions. So we try to shine a light on those times when people have to move, like I was talking about earlier, when someone has to go out of their home into a nursing home. We help with that. We also help care for the providers who are taking care of these patients because it's really stressful. What's hospice? So hospice is a type of palliative care. It's a philosophy, it's a healthcare service. It's a type of care that's provided to people who are facing a life-limiting illness, who want to focus all of their medical care on comfort. It's highly individualized, and there's a lot of myths out there, so I want to just debunk some of those myths. Number 1, hospice is not a place. It can be a place, but it's not just a place you go. It can happen in your home. It could happen in your nursing home if that's your home. It's also not just for the final days of life. People really derive a lot of benefit from hospice care when they're receiving it for weeks to months. And this one's a little bit controversial, at least in my field. I'm going to say that hospice is not necessarily limited to just 6 months. CMS says that hospice is for people who 2 doctors think the prognosis for a patient is about 6 months or less, and that is true. However, if you live to that 6-month point, hospice is not going to immediately give you the boot and kick you off of their service. If you are thriving and soon to be improving, maybe hospice isn't the appropriate service for you anymore. But if you're continuing to have decline, you can stay on hospice. And I point that out because it happens for a lot of people with dementia. And if I have time later, I'll tell my favorite story about that, but I'm running out of time. It's not giving up. These are things I hear from families. It's not giving up. It's not just morphine or opioids. And then a practical consideration is that hospice is not 24-hour care in the home. So families need to gather together caregiving resources to help support them taking care of their loved one at home. How does hospice help? It tends to be a bigger team. One of the hospices out in the conference had a nice diagram with even more specialists on their team, but there's lots of people who come out and figure out how they can help the patient and family. They also do symptom management. They do education. The decision-making also continues because lots of things come up as you go along in your illness. They do spiritual care and psychosocial support. There is limited help with personal care. About once a week, a home health aide can come. One of the great benefits that hospice gives is 24-hour phone support. So if a crisis happens in the middle of the night, the family can call hospice, not 911. And hospice will actually send out a nurse if they need to in the middle of the night. They also provide and are actually required to provide bereavement support to families for 12 months after the person on service dies. And many, many hospices also provide bereavement resources in the community for anybody who's bereaved in the community, not people who've used their services. People on hospice who have dementia, so this is specific benefits for dementia patients, they've been shown to have fewer hospitalizations, fewer deaths in the hospital, better pain management, better management of shortness of breath, better mental health care, and overall fewer unmet family needs. So it does good stuff for people with dementia at the end of their life. Here's the tricky thing. You have to have really advanced dementia to be eligible for hospice care. I don't necessarily expect you to be able to read all these things, but I wanted to show the whole FAST scale, which is the scale that CMS gives us as hospice and palliative care docs to help figure out prognosis for people with dementia. It starts with very mild symptoms and gets to the point where somebody is stage 7, which they call severe dementia. And I envision it as somebody who is essentially bedbound and unable to speak. I want to just make one point that although this is the scale that's given to us to use, it was validated in a very small group of patients, about 40 patients. So it's not actually a great tool scientifically, not highly predictive of prognosis. But the bottom line is what Medicare is telling us right now, to be eligible for hospice care under Medicare, you have to be this FAST stage 7, which is severe end-stage dementia, bedbound, and nonverbal, basically. You might have a couple words. You also should have some complications along with that, such as weight loss or eating problems or infections. And I would say almost everybody who is at this stage of dementia has those problems. And then another thing that's really key that I think gets sort of put aside is that the goals need to be appropriate. So the patient needs to, or the family needs to, speaking on the patient's behalf, needs to highlight that comfort and quality of life are the key goals for the person. So they have that 6-month prognosis, and their goal is to stay put where they are and stay comfortable. So those two things make you eligible for hospice. So I want to move on to how providers can help people with getting through all these different decisions and complicated things that you need to deal with on this path. The first is advanced care planning. I talked a little bit about that at the beginning, and I think that providers, it's very important for providers to help with that. I actually think so we heard that everybody in the room should have a cat, I think, earlier. I would argue that if you're going to take away something that everybody in the room needs, it's an advance directive. Who has an advance directive in this room? Good. So it's probably 50%, I would say, maybe. That's interesting because we have a room of people who are working with people with dementia. So about half of us have advanced directives. The other thing that providers can do is make referrals, connect people to resources, and a lot of people have talked about that already. The big piece that I wanted to close up with is that I think providers can really help by having conversations in the right way. And the nice thing is that we're going to move right into a discussion of the PULSed form after this. And so I think we're going to kind of revisit what I'm talking about on this last slide. It's about having providers help families identify what the goals of care are, and then providers make recommendations to families about what treatments actually meet those goals of care. Sounds really simple, right? Like you go in with an infection, I have a pneumonia, I want to cure my pneumonia, can you recommend an antibiotic? Doctors are really good at that. But if you go in and say, I really want my loved one to be able to stay home and be able to travel to Florida to a family wedding, how do I manage that? It's a whole other ballgame. And it freaks doctors out. So a big bulk of my work is training doctors mostly, but training lots of disciplines on how do you start to approach these conversations which feel really scary. And I'm just going to give you a few buzz phrases that I teach. There's a million more, but they're organized sort of in the order of how a conversation might flow. So the first one is assessing what the patient or the family understands about their illness. What have the doctors told you about your loved one's illness? That's like a really common question. It's a $1 million question that I teach all my medical students and residents to ask. What have you heard so far? Sometimes they're going to say, I've heard nothing. Sometimes they're going to say, I have community-acquired pneumonia. You're giving me IV ceftriaxone. I should be out of here in 24 hours. Either way, you've learned a lot, and you can meet the patient and the family where they are. So that's key. Start with where they're at. And then it's moving into breaking bad news, and you need to know, do they want the bad news? Are they in a headspace to hear the bad news? Do you want to know about how much time is left, or whatever the bad news is? This is about delivering prognosis, of course. You might also ask, are all the right people here to talk about your mom's care right now, or do we need to get other people in the room? Sure, that's not as convenient, but it's really important because if you don't have the right people there, you're not going to get the conversation accomplished in the right way. Once you've delivered the prognostic information, let's say, it's about figuring out what's important to the person and the family. What do you think his hopes would be if he knew this? What are your hopes for him? What are your hopes for yourself when you're talking to caregivers? And what do you think he'd be most worried about? What are you worried about for him? These are really important questions that help the provider get to the goals. What is the most important thing right now, given all this that's going on? So you gather all that information, and hopefully the provider is able to use that information to make a recommendation. Based on what I know about your goals, here's what I'd recommend. And this could be talking about code status, for example. It could be talking about a feeding tube. It could be talking about going to the hospital. These are the kinds of conversations I wish that the providers had with my dad when my grandma was going through this. The other thing I'll say is that we are absolutely still and ongoing, always going to be in the process of helping all providers get better at this. And so I think that patients, families, caregivers can also really advocate for this type of communication. And I want to just call out at the Alzheimer's Association booth, there is a pamphlet about end-of-life care for people with dementia. And I believe it's on the back. It says questions to ask the doctor. And these two questions will really help guide the conversation. And so I was so pleased to see them there. Are we doing all we can to give this person the best quality of life? And does the treatment match what he or she would have wanted? Really useful. So pick up that pamphlet. It also summarizes most of what I've talked about, actually. So going back to what happened in my family, all those yellow circles, actually all the branch points represented different decisions where an extra layer of support would have been helpful as we interacted in and out of the healthcare system. And it would have lowered the stress on the family, on my grandmother, and I think it would have relieved suffering. And perhaps she wouldn't have had, it wouldn't have been such a shock when she had that really precipitous death. So in summary, these are sort of the take-home points. Well, number one take-home point is do an advance directive if you're one of those 50% of people who didn't raise your hand. Number two, what is palliative care? It helps patients and families with the symptoms and stress of dementia. What is hospice? It's a type of palliative care. It's a healthcare service focused on maximizing quality of life at the end of life. And providers can guide decision-making with discussions of goals of care. And families and caregivers can help those conversations by asking the right questions. That is the end. Thank you.
Question.
How does one obtain a palliative care team?
That's a great...
And is it Medicare covered?
Yes, it's absolutely Medicare covered for sure. And palliative care comes in a lot of different forms. So the easiest way is to inquire with a primary care physician as to whether there are outpatient palliative care resources. I imagine this person's in the community. Palliative care teams are present on the inpatient side of the majority of U.S. hospitals at this point. Outpatient palliative care is growing, although I'm pretty sure in Orange County there are resources for outpatient palliative care. And then some communities are starting to have home-based palliative care. Some of the agencies here offer some form of palliative care, which can be accessed through primary care referrals. At UCSF, we actually have a house calls practice where the primary care doc makes a referral and then they go out and make a house call. So it looks a little different everywhere, but I think the best place to start is with the primary care provider.
Can I ask you to read this? People can't hear me.
Oh, yeah. When one lacks the capacity to speak, how does a carer determine a pain intervention? That's a great question. And I think the question number one is, how do you figure out if the person is having pain? And I'm guessing that there's a lot of people in this room who are really expert at doing that. Particularly in the sort of nursing realm, there's a lot out there in terms of what are the nonverbal signs of pain. And there's even some pain scales that nurses use in nursing homes and hospitals to determine whether the person is in pain, including things like a facial grimace, clenching, looking uncomfortable, even some of those neuropsychiatric behaviors that we heard about right before lunch can be indicators of pain. And then how do you determine a pain intervention? It's personalized and depends very much on what the person's medical conditions are, what other medications they're on. Although we generally try to start with even non-pharmacologic interventions can be helpful. Positioning, warm compress, cool compress, mobility exercises, things like that. And then we usually move to Tylenol, which helps a lot of people. And then we might move to opioid pain medicines if needed.
Can you please tell your favorite story now?
Oh, yes. So thanks for asking that. I love telling my stories. So when I was a fellow in 2007, I was at the West LA VA, but I also spent a lot of time with a couple of the community hospice agencies making rounds with their medical director. And we visited a home in Pacific Palisades, and I remember it clearly because it was a fancy neighborhood. And she said, we're going to go visit this woman, and she's very instructive. You'll remember her, and I do, a long time later, because she's been on hospice care for dementia for a while. And we went to see the patient, and indeed, there was this woman in bed with a very attentive caregiver. And I noticed that it was like a construction site. So here's what happened. She owned her home. The house next door belonged to her sister. Her sister died. The family put the home on the market. A young family came, took a look at the house, said, I love this location, but it's not quite enough space, and we want a place we can really fix up and make amazing. And they said, well, her sister lives next door and she's on hospice. And they actually made a deal where this family bought both homes, and in the deal, it was written out that this woman could stay in her house until she died, and once she died, it would transfer over to the family. And that had happened 2 years before I went to see her with hospice. So it was a great reminder of how people can have this very slow decline and continue to be on hospice. And it's incredibly true in the situation of dementia. I think it's one of the hardest diseases in which to predict prognosis. Oh, yes. Do you have an opinion about thirst and its meaning in a patient who is in their last days? Is it related to pain? That's a really good question, and I don't know is the short answer. The longer answer is that the best that we can tell and the best that we know, people generally do not experience thirst in their final days. And the way I tend to describe things like artificial hydration to families is that as the body is kind of slowing down, it really doesn't handle extra fluid very well. Everything is slowing down. And so when we have somebody who's dying and we introduce artificial hydration in an IV, the fluid tends to collect in the lungs, collect in the legs, collect in the belly. And to me, that's reflective of the fact that their body just isn't handling fluid very well anymore and tends to cause more discomfort at the end of life. So that's why we recommend generally against artificial hydration in the last days. And is thirst related to pain? I'm not exactly sure the meaning of that question, but I would say that the way we do address the symptom of dry mouth, which can certainly cause discomfort, and maybe the person asking this question is thinking of pain as general discomfort, is actually with those oral swabs that a lot of you are nodding. And of course, you all know you can dip them in anything you want. I think many of them are minty, so you don't want to mix it with coffee or whatever. But lots of families find that their loved ones, a lot of we teach our families, and the nurses really teach the families how to do mouth care for patients. And I think that addresses a lot of the dry mouth, which is an uncomfortable part of having your mouth open and not drinking anymore.
So my question is about the diagnostic criteria for someone to be eligible for hospice, and you said that the FAST scale was not highly predictive.
Yeah.
And so I was wondering if it were up to you to make criteria, which obviously you have some, play in that, but what other recommendations would you?
I wish I had play in that.
Yeah.
So my big, if I could change the world thing would actually be to have an entirely different Medicare benefit for people with dementia. Oh, wow. I don't think that the model of hospice with the 6-month prognosis actually fits what dementia looks like. And so I think that's actually the direction in which we need to go. It's really hard if we use prognostic indicators only. There's other things you could use. There's something called the Palliative Performance Scale, for example, that is somewhat predictive of length of life, actually, in all diseases. And then there's other scales you can use. You'd end up with, if you use those sorts of scales, I think you'd end up with lots of people on hospice who are only on hospice for days, and that's not the point. So my answer to your question, it might have been a turf, but it's really, I think we should change the benefit.
Thank you. You said that you wanted us to give a copy of the Advanced Healthcare Directive to our doctors.
Yes.
Isn't there another single form that can be filled out and passed on at some point? And
are you a plant? Are you talking about the California Post form?
Yes.
Somebody must have paid you to ask that question, because that's the next time.
We'll pay you at the end.
We will talk, yes. However, the key difference and the key point that I want to make, and when I was saying everybody do an advance directive, truly everybody should have an advance directive. Knock on wood, you could get in a car accident and not be able to speak on your own behalf anytime. A post form, which is next up, is really for people for whom we have some sense that time is shorter, maybe about a year. So there are some different circumstances in which you might use one or the other. Okay. Thank you.